the topic today is harsh punishment. We're going to focus on physical and not severe child maltreatment. That's another kind of action requirement, but pushing, grabbing, shoving, slapping, hitting, that kind of physical stuff that happens. And we're going to talk about its impact on children. We're going to think about why this is happening. Why do parents do it? And I'm going to present an approach to pediatric early intervention to a preventive approach. And then I'm going to introduce a moment of care decision support training that is a webcast, related intervention. And with that, I have to confess that Barbara and I have conflict because we develop and distribute the product Chattis. And I'll be talking about that as well as other approaches.
And Emily has a slide for disclosure too, and she doesn't have any conflicts.
I have no conflicts.
In any case, there's been really a ton of research. When you first started thinking about this, it may have been, before the 90s. If you read studies, there was always this issue of, physical corporal punishment was linked to long-term adverse outcomes, but is it a cause and effect kind of thing? And then starting with around 2000, there were a series of many prospective studies. And in these studies, they were able to match kids by behavior and other socioeconomic variables, those who were corporal punishment, had corporal punishment who didn't, and follow them over time, not just look at the outcome and go backwards. And there have been several meta-analyses of these studies, and it's clear, 10 big meta-analyses, one that doesn't quite show these negative effects, but the overwhelming number of studies do show a number of outcomes that are really, really important. Negative social outcomes, insecure attachment, poor relationship between parents and children, as you might expect, aggression, disruptive behavior in school, lack of acceptance by peer, crime, delinquency, lower cognitive and intellectual outcomes, mental health problems, especially anxiety, depression, and even suicidal ideation, increased use of abusing your own child or spouse, and also physical health conditions, frequent ED visits, and something I'm going to dwell on a little more, decreased moral internalization. The thing that the inflictor of physical punishment has in mind, I'm going to teach you a lesson kind of thing, doesn't work out. There is one positive outcome, and only one positive outcome that has been found in studies of physical punishment. And it's not in all studies, but it's clear that immediate compliance does happen. And that's an important one because sometimes doctors are quick to discount that it doesn't work, but in the moment it does work. But no study has found physical punishment to have any long-term positive outcome. Now, this study I wanted to focus on a little bit because here, this was the article in Pediatrics 2013. They pulled out harsh physical punishment from maltreatment or abusive cases, and they adjusted again for socioeconomic, sociodemographic variables, family history of dysfunction, really a lot of stuff, and tried to get at, what's the outcome in a group of children who, at least adults who reported that their parents sometimes or greater did hitting, grabbing, shoving, slapping, that kind of stuff. And what they found is similar to the studies I talked about a moment ago. It was associated with aggression, delinquency, physical injury, higher likelihood of mental disorders, including mood, anxiety, substance and personality disorders, and physical things like arthritis and obesity. The list is longer for abuse, but even this would be in the mild, not reportable corporal punishment. but as I said, the intention of I'm going to teach you a lesson just doesn't work out. And there are a number of studies that show that. And one is there have been studies where they look at kids after the parent gives them instructions, tells them what to do, and may physically punish them, maybe not. But they had a parenting style of corporal that included corporal punishment. The parent leaves the room and they watch the kids of parents who had that style versus parents of a non-physical punishment style, and the kids are more likely to not do what their parents say when they're not looking at them and there's no physical punishment being threatened. And then some interesting studies of preschoolers in punitive versus non-punitive preschools. The ones in punitive preschools are more likely to be sneaky and lie about what they do. So another issue that comes up, and if you just think about it a little bit, aggressive kids could elicit more punishments. And we all know, if anybody takes care of ADHD kids and kids with difficult temperament, they are more likely to draw punishment. And so maybe it's all genetic, and these relationships are just the genetic fulfillment. But Barb and I had a chance to visit these primate labs, Poolsville, Maryland. It's amazing. And they have had a whole series of studies looking at the genotype and the neurochemistry of monkeys who are more vulnerable, and putting them in different kind of fostering situations, some more neglectful, and showing that while these primates are vulnerable, it's not inevitable, and if they get treated well, you don't see these kinds of issues emerge in their development. There are some human studies now, studies of this one particular gene, whether the gene was present or not, and if there is a low active gene, the individual is more likely to be antisocial, and if they were maltreated, and only slightly different in that dimension if they weren't maltreated. This is a group that had a much higher outcome in terms of rapes, robberies, assaults. So it's an interesting parallel to the primate studies, and there's more needed to be done. When you look at randomized controlled trials of alternative disciplines, you don't change the genes of the kids, but it does decrease aggression. So in conclusion, genetic vulnerability is true, but it is not the fate of the children. Another issue that always comes up is maybe in some cultures, maybe it's the norm in some cultures, and we're being, cultural relativism. Such as Kenya, where physical punishment is used as a norm, and it can be done in a controlled fashion in the context of a nurturing relationship. It's looked on as culturally acceptable, and in fact, a sign of good parenting. How is that compared to Thailand, where there's very little physical punishment in the culture? And the conclusion is, yes, in Kenya, in that context, some physical punishment has less bad effects, but clearly the moderating effects of ethnicity are only at the ordinary or moderate levels of physical punishment. Extremely harsh discipline that shades into physical abuse is equally a problem for all children, regardless of culture. And that kind of research has, if you are aware that in 1990, the General Assembly of the United Nations passed this Convention on Rights of Children. And so what's come of that is, children have rights and parents have responsibilities, and there is a declaration. And in fact, this kind of research we're talking about is sometimes through changes in laws, is actually there's evidence it's changing our culture. And that's true with some exceptions. The United States really, when you look at other countries in the world, 41 other countries prohibit physical punishment after that United Nations declaration, not the United States, and actually not Canada either. And when you look at school corporal punishment, your school-based clinics, every industrialized country in the world prohibits school corporal punishment except the United States. There are 29 states that do, but we don't have it as a federal law. This past year in our culture, people who pay attention to football heard about this player, NFL player, Adrian Peterson. He used a switch. It was a slimtree branch to whip his 4-year-old son. And how was NFL going to deal with this, especially in the wake of the domestic abuse from the Baltimore football player? But in that time, 70% of Americans approved that was really okay. And then if you look at other surveys, half of adults report that they've had a history of physical punishment in their childhood. And not too long ago in North Carolina study, about half of parents reported slapping or spanking their children in the past year. And this varies. Boys get spanked more, African Americans more, Asian and Pacific Islanders less. So what we're up against often, and I know you've all heard this, and this is especially when it comes from a person in the legislature, the idea that yes.
It's Emily. Could you go back a slide? I just wanted to. Can you go back one?
Yeah.
So I guess,
Sure.
I know you said up front that you're talking about harsh physical punishment, but not child abuse, right?
Yes.
Right. So I guess what's a little confusing is that Adrian Peterson was arrested on charges of child abuse.
Right. No, I'm not talking about, I'm just talking about culture.
Right, but are those numbers there about abuse? The 49% report a history of physical punishment, is that abuse as in the Adrian Peterson? I'm confused about what some of those numbers mean.
Yes, thank you, Emily. I believe, and I don't recall that study, I may be quoting it wrong. This was physical punishment, not abuse. You're right. Adrian Peterson was an issue about abuse, and I'm not talking about abuse, but I just did. But I raise it just because the U.S. culture and what if the controversy that it stirred up, whether some people thought that wasn't abuse, and it should be permitted. That's all. The only point I was trying to make.
Okay, thanks.
Sorry.
It was abuse because he left
it was
marks.
Abuse.
He left marks with an instrument.
It
right.
was abuse. It was abuse. But it just brought the conversation to the fore recently, and some of the surveys, do people think it was okay about what he did, even though it was, strictly speaking, certainly abuse because he did leave a physical trace. But so this is the issue that we're up against, I believe, when we try to advocate in the U.S. I was spanked and I am okay. Now, this data is true, but it wasn't that every kid who was spanked did have those bad outcomes. Some proportion of people are lucky. They're not adversely affected. But the notion is the more children that experience corporal punishment and the more frequent and the more severe it is, they are at risk for greater for problems of aggression, depression, regardless of their cultural background. And it is something that relates to severity and frequency. So that's the issue that we have to. So I wanted to just pause a little bit and see how we understand these outcomes. And the studies of when they look at disruption of parent-child attachment resulting from pain inflicted by the caregiver, and then there was depression, and then they have more psychological data on the children, and they statistically can relate the perception of parents' punitiveness and withdrawal of love to depression, and perception of low self-esteem to trace back to broader internalizing problems like depression, anxiety, and suicidal ideation. So, and then people talk about potential neurochemical mediation. We'll talk about that more. Increased levels of cortisol, a disruption of the brain's mechanism for regulating stress that's happened. And I wanted to include this quote. This is from a parent who was just talking about her experience. And she was really a well-behaved young lady, a little girl, and grew up. And what she said was, the message I got from them when they hit me was not, what you're doing is bad, don't do it again. The message I got was, we don't love you. And I think that's what we're talking about, the way we're understanding how that could lead to depression and internalizing symptoms. Thinking about aggression, there are ways to think about that, about modeling.
Ray, it's Emily again. I'm sorry. I want to just clarify. These kinds of experiences do not cause depression, and I think that's really important. They may precipitate out depressive symptoms in a person who is otherwise vulnerable genetically and for other reasons to have affective illness, but abuse,
Correct.
harsh physical punishment does not cause depression, and I think that's a really important frame to maintain.
Correct. Now, that's what I was trying to say about the genetics earlier. Some people are vulnerable, and other people, it wouldn't affect them at all. But as a group, if you talk about group effects, and it does cause it, it is associated with it in
not causal,
studies
associated.
as much as you can. It is a group. Now,
but it's not causal.
It's clear. Okay.
Yeah, that's just important.
Okay. It's linked we can come back and talk about what's causal, but it's linked.
It's
and
linked.
There
and
are individuals, and particularly it's causal in vulnerable primates is the best we can say. That's the hardest evidence. When we know their neurochemistry and we subject them to certain kinds of rearing, then we could say it's causal. It is related. There are many, many factors. I'm going to come into the other associated factors. It's not so I don't want to give a overly simplistic, and I appreciate your making sure we don't get overly simplistic about that. So I just wanted, there's some ways to think about this that I'm trying to sort of describe to help us understand what might be involved. And if you think about modeling and aggression, I think the studies of first graders, they observe a 1-minute video of a boy being yelled at and spanked for misbehaving, and then afterwards they start beating up on their dolls. And then the issue of you can reduce harsh punishment in parents by an behavioral intervention, and there's a significant reduction in child aggression. There is a direct causal effect of pain with a reflex of aggression. Everybody experiences that themselves, and momentary aggression, certainly. And thinking about being angry at a parental discipline may spill over to a stance of resistance and anger for other authority figures. So these are just associations. I'm just trying to paint a picture of how we're thinking about this right now, and there are neuroimaging studies that suggest that physical punishment in populations may reduce the volume of the brain's gray matter in some areas related to IQ. Why is it related to when you sort out other socio-demographic factors, its relationship to cognitive development is there, and later drug abuse. Well, these are hypothetical things I'm talking about now. Hypothetical. So physical punishment can cause alterations in dopaminergic regions associated with vulnerability to abuse and drug addiction. And then why would it be linked to chronic illnesses? And this is a subject that's come up a lot following the ACE studies of adults who had a variety of physical problems that were related at the population level to their experience of not just, this is not just punishment, but harsh rearing. And the notion of a toxic stress response, dysregulation of the hypothalamic pituitary adrenal axis, these are theoretical notions now. We don't, people are talking about chronic illnesses. Why is it more chronic illnesses? Well, when you mess up the secretion of stress hormones and you get higher pulse and blood pressure and maybe even alterations in sleep, these are, again, hypothetical ideas. Feelings of shame and hostility, and some research has been associated with changes in the immune system. I say all this not to be definitive about any of it, but to say this. So my conclusion, Emily, is that why parents use harsh punishment. And the first part I conclude from all the brain possibilities and these relationships is it looks like people get to be wired in their brain the way they were raised. And theoretical way to think about that is we know neurons fire even when we see somebody committing aggressive behavior without acting. It's kind of a simulation practice when we're watching this, and especially when it's more proximal to you. So they're wired that punishment becomes habitual, maybe even addictive. That's theoretical talk now. That parents get deluded into thinking that it works because bad behavior usually stops for the moment. It may be replaced with crime, but it stops for the moment. And that the idea that you would think that people who have suffered from physical punishment themselves would think it's a bad thing because they had suffering. But if they turn out okay, there's a kind of cognitive dissonance that is people talk about. It must have been okay because the suffering gave it some purpose. It must have been for my own good. That's what my parents said. It was for my own good. And they come to a worldview equating power with aggression and humiliation.
If I could just add that parents actually have been bothered by their child's behavior, and when they hit the kid and the behavior stops, they actually get reinforced for doing it also.
Yes.
So because they have some relief in the moment.
They have relief
so
in the moment,
forget that part.
and it stops. And people, I think one of the things doctors say, it doesn't work. It does work for the moment. So I'm saying I don't have a way to change the wiring of the brains of parents or even change their worldview, equating power with aggression and humiliation. I couldn't even get them to not vote for Donald Trump, much less change their view related to the kids. Okay. So, but I believe that this is how many of you watched the movie Inside Out? Barbara and I watched it. It's a cartoon, and it's a cartoon about the inside of someone's brain. It's
but
just
you guys would all love this movie.
This is a wonderful, and this is the moment I want. It was a really poignant moment. This wonderful, empathetic father moved to San Francisco from Minnesota, and his daughter's upset and is disrespecting in the moment, and he comes down hard to teach her a lesson about being respectful, not understanding why she's upset. Later he understands it, and he becomes empathetic again. So what I'm proposing is something I'm calling developmental prescriptions. So first, what we want to do is help parents think about their child's behavior differently, less plugged into the aggressive reactivity that might be wired in their brain. It may be like a cognitive behavioral therapy. What I'm talking about is talking to the parent based on knowing about development and specific examples. I'm not talking about saying, don't spank, use timeout as a blanket kind of statement. And what I'm going to be talking about is a way I'm thinking of, the way I think about it is to elicit the wiring of empathy, because while they may be wired to be reactive to anger and physical punishment, most parents are, unless they're sociopaths, they're wired for empathy too, rather than anger. And so we want to elicit the empathy in the parent, and I'm going to suggest that developmental prescriptions work. So let me give you some examples of what I'm talking about. So this is like a pediatric role, because pediatricians get to see kids as they grow up. I'm talking about young kids. So aggression in 2-year-olds. One of the most common cause of aggression in 2-year-olds is the kids have the idea now of possessing something. It's my stuff. It's associated with their identity. And they are having a property war with anyone who tries to take it away. So the developmental prescription here was if you can't that we know they can't share because they're not developmentally capable, but they can take turns. So you could say, you've got to take turns, or I'm going to put the toy in timeout until you can take turns. So if you did that kind of approach, this could be called an inductive method rather than a power assertive parental method. You're setting limits. You're saying you can't be aggressive over that toy, and there's a logical sequence with reasoning, explanation, and it makes sense developmentally. So that's one kind of example. Here's another example of a common behavior, aggressive behavior in toddlers, biting. And here's my developmental prescription. The developmental prescription here is the parent, when bit, reacts in an exaggerated pain reaction, turns away from the child. They do it in a few seconds. No talking. The other one, unlike what I said about turn taking, there's no talking here. And if they know you've done it properly, because the child will fall to the floor and cry, if they don't do it right and they try to fake it, the child laughs. Now, the reason this works, and it does work, I actually did a parent group a few weeks ago and suggested this to a kid who was mostly biting in daycare, but also at home. And the mother came back. First she said yes, she tried to do it, and he laughed. And then I told her, I said, you may need some acting lessons, because you got to have this facial expression of anger and then turn away for a few seconds. Then she did it, and she said not only did it stop the biting at home, but the daycare teacher said that the kid suddenly became well-behaved. And what's happening here is that toddlers are driven to learn how behaviors affect the fluctuation of affective signaling by especially their parents. And they are driven to figure this out. We can talk about this more. And this kind of recipe strikes both the fear and loss of the parent's affection and their new capacity for empathy with the parent. It is a one-time learning kind of thing, and parents who talk too much, we say, oh, give explanations and logical stuff, they're the ones who have this more, or parents who are inconsistent in their reaction. So another common young child thing are tantrums and upsets. Well, upsets happen. And our first in the developmental prescription is find out why. Always try to find out the cause. And if it's a development appropriate expectation, that happens a lot. It's an inappropriate expectation for the child. But also give the parents an understanding of the neurophysiology of tantrums. There's 3 phases. First, there's a window of opportunity to distract the child before it happens. Once the child's aroused and the upset explosion occurs, it must last. It must last for 90 seconds. It's been well studied. After that time, there is a fragile recovery. The child tries to repair their relationship with the parent, and it's clear that any input right then, they can go right back into the tantrum such that it doesn't even look like they stop. And when you hear that a tantrum is going on for 10 minutes or more than 3 minutes, you can bet that the parent is not just standing there in quiet sympathy for their anguish. And so that's a developmental prescription. Because parents, it also elicits anger in the parents, and there's punishment. Another example that's pretty common in young kids is transition behavior, and this is really gets me. I think it's the most common reason for what you hear about is he just doesn't listen. He's stubborn, he's selfish, he only does what he wants to do. You hear this in ADHD type temperament, other developmental disability, but it's pretty common in all kids. So my developmental prescription here is the parent has to understand and appreciate that it's actually good for the child to be mentally absorbed, even if it's only in their own imagination. It doesn't look like they're playing with the Legos or something like that. And that they're resistant to disengage for something boring, like brush your teeth. And second, you should accommodate their need and use distractive strategies. You want to touch them, get eye contact before you talk to them. If they're younger, you might be able to get to a point where you can distract them. You could use an egg timer, create upbeat routines punctuated with music and rewards. So the idea that there is new habits that have to take place over time, but the main thing is that parents, again, with their worldview, has looking at this with their moral lens. And if you take off the moral lens, you unplug some of the angry reactivity and replace it with a challenging and workable approach. So the idea here is with maltreatment prevention during routine care. You have to create the auspices for it, and sometimes parents aren't expecting this kind of discussion. They're asking about what's the hardest part of raising that 12-month-old or whatever age. But there's an additional challenge that one has to realize. This is in the context often of family stress, parental depression, intimate partner violence, all these things in the moment. The parent is going to often lose any advice that they hear from you. So that is really a challenge. And so what I want to talk about now is an approach to those two challenges using our web-based pre-visit screening decision support for both family stress and child
Ray?
behavior.
Ray,
Yes.
could I just make a couple of comments on, because you've covered quite a lot of territory. It's just a lot to absorb. And
Right.
I guess, one of the things that I try to think about with families, because these families can be very difficult and challenging in many ways, because it can feel like we're starting from different starting places in the framework that we use and thinking about what's good for kids. And I think that can often put clinicians in an uncomfortable place. So one of the things that I try to do is talk with families about behavior always serves a function. And even naughty behavior and behavior that we don't like as adults is serving a function. And part of what we need to figure out is, what is that function for the youngster? And a lot of times in these kinds of families, the function of that behavior is to get some attention, because otherwise they're ignored. And even though it's negative attention, they'll take a punishment over no attention at all. And I think that's a fundamental principle about behavior that is really important to help families understand. It sounds very simple, but it's actually very complex for families who come with the framework that Ray's been describing to think about behavior in this way. They see intentionality, he's doing it on purpose to irritate me, instead of he's doing it for a purpose that we can change. We can help families reinforce different behavior patterns if they understand what a reinforcement schedule looks like. And I think that becomes a really critical piece of education for families, which is that the reality is parents make behaviors happen more, and they can also make behaviors happen less. And it's how they respond to the behavior that's going to determine that. But if we don't explain that to families about the why we're asking them to do things differently, I think it can be very frustrating for them. And so before I would ask a family to do a task, I want to begin the conversation about why I'm going to give you something different to do, and it's because they have the power. And I think often families in this situation, the parents, although they may be aggressive in many ways, they feel powerless in the face of their child's behavior problems or what they see as the behavior problems. And part of what we have to do is have them feel empowered, but in more constructive ways. And I think that becomes important. And at least most of the families that I've seen that have this kind of aggressive form of punishment with their kids, when you ask them really frankly about whether they think it's working, they will say, no, not really. It works short term, but it's not working. And they mostly don't like that they're doing it. So there's leverage there if you create a moment where they can feel safe enough to acknowledge some of those things that, this is what happened to me, and I don't like that I'm doing it. I want to do it differently, but I don't know how. And I think it's really important. I would just really emphasize as a preamble to intervention that we need to have that framework as much as possible, because it's very easy to get into power struggles with parents like this as the clinician.
Well, what Emily has just elaborated on is exactly the idea of getting, and I didn't pay enough attention to that. We're getting examples. Tell me, it's not giving a recipe before you give an example. And I gave recipes here, but inherent in that is helping the parent understand, and that's what I'm saying, unplugging their reactivity when they understand why it happened. And it's not always just reinforcing and not reinforcing. The pediatrician also has to understand why in this moment of development, why this is happening, why is the biting happening, why is the aggression happening, and explaining it. And explaining it is disarming them, but it's done by a specific example. That has to be the starting point of the explanation. And so anyhow, that's certainly, I'm glad you elaborated on that. I don't want to, these aren't recipes. They require that you know what the cause is. And those were just examples. And so here's what the challenge also, though, is that you must pay attention. They can understand for the moment, but then they go back and they're being abused. And how do we address all those things at one time? So we've been working on this at Chattis, and I'm going to share with you our approach, because the approach has to do with dealing with eliciting the idea that their family stresses and dealing with it and beginning the conversation using motivational interviewing. And that's a challenge to introduce motivational interviewing in primary care, because it takes extra time, it takes training, and we need to, they may not feel they have a role in dealing with these family issues because they're pediatricians. And their challenges to addressing behavioral issues, their time and understanding of some of the developmentally appropriate behaviors, and they may not be practiced in talking about it. So I'm going to give you our something we've been working on here. And what we've done is adapt Howard Dubowitz's SEEK screen that screens for food insecurity, parental depression, extreme stress, harsh punishments in there. It's in there with these accompanies, intimate partner violence, substance use. And he has had 2 randomized control studies that showed he was able to reduce child maltreatment outcomes when this is used in primary care. We're trying to adapt it further. I'm going to show you. Another clinical challenge is that we may not be knowledgeable on some of these reasons, functions, as Emily said, that children have depending on their developmental needs. And these are difficult conversations when parents are bringing their kids in for a shot, not expecting to talk about sensitive stuff. So basically, our adaptation, we're trying to help with the time it takes because we're getting information prior to the visit. We're doing the seek screen. If it's positive, we start a motivational interview and collecting additional data with the computer. And we're going to help solve the time problem by doing documentation. You get some auto text. Some of the workups have been done by the computer. And we're going to help time issue by some post-visit individualized messaging and individualized handout kinds of stuff. And training is done in the moment of care, and there are teleprompters that suggest language. It is, if doctors are not practiced at talking motivational talk, there are some teleprompters that have scripts there and other post-visit kinds of chapters and videos available. So I'm going to take you quickly through an example case. We're really running out of time. So this is a parent who's taking the seek. That's how it's introduced. Do you find yourself sometimes you need to hit or spank? Yes. Are you getting help? No. What's the most challenging behavior? So we're looking for, is there a function to the behavior that we can begin to talk about, begin the discussion? Okay, here's an example. It doesn't stop doing things. Do you want help? This parent says no. What's the main thing that's getting in the way? I think it's going to get better with time. And if it were to continue, what would you be open to? And this parent said parenting classes. Is another question. Have you felt depressed? This case, yes. Do you want help? Yes. Okay, now we're in this patient-specific template. These are new screens that people using Chattis haven't seen before that we're now piloting. So you get some red tabs. This was red, and you pick which one you want to look at first. Harsh punishment. The depression was positive. And the prior screen, you could see that the parent said they're ready for help with depression. And there's some words there. I see you checked off that Sam's difficult to take care of. Difficult behavior is common. Sam may be especially challenging. You want to give them some off-the-hook way of talking. And then the depression one, you could push that button. In this case, you see it's not going to be so hard because the parent is asking for help, and you can make a referral. We won't go down that line. So with this behavior, you might decide to weigh the pros and cons of getting help for the child, or go right into I'm saying a developmental prescription, an explanation for the behavior, a way to reframe it and help the parent think about it differently. In this case, if you were going to take on weighing the pros and cons, I see you haven't gotten help. The computer is giving us the answer that they said. It will, I think it will get better over time. Some things do get better. These problems can take a lot out of you and so forth. There are the cons of it. And then you can go to the plan area, and you can have, there are some suggested ways of talking about this. This is a transition problem. It has the function for the child of wanting to continue doing what they're doing. Here are some ways to talk about it. Sounds like your child is engaged in something really interesting. This is common. With kids with good imaginations, we're trying to reframe it, have the parent think about it in a different way. There's some these recommendations, hints. It talks about why we're talking about these things. We're framing a transition problem in a positive way, intense, curious, encouraging parents to get the child's full attention, and helping the parent to see they need to learn transitions as a skill. We're going to, at the same time, have some notes put aside that could be a handout or can go into this care portal, and some resources. We can preview the handout. This is the handout we've created during this visit. about notes about transitions, resources, and a local therapist as well. The parent can go into the memory book and see visit notes, open them up, and see the kinds of text that I showed you earlier. There after the visit, if the doctors pique their curiosity, there are videos that are available and chapters. So I'll stop. I went too long. I'm sorry. But so that's available now. All that stuff isn't necessary. You can have these conversations. There are other ways to have it come up. The reason we're doing this is that we think it's a time crunch to do motivational interviewing, that to have resources that are for the particular parent. So let me stop and ask for questions.